evening to all of you, and good afternoon and good evening to all of us who are joining from the rest part of the world. Today, our guest speaker for the day is Dr. Hervé Tilly from France, and he's going to lecture us on large B-cell lymphoma, European Management Guidelines in 2025. This webinar is brought to you by Mumbai Hematology Group, supported by Roche, Unipath, Lucid, and Nirvil Life Sciences, and managed by Perfect Square. I thank Team Roche, Unipath, Lucien, and Nirvin, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Nitin Gupta from Delhi, our guest speaker for the day, Dr. Hervé Tilly from France, all our discussants who are themselves very eminent hematologists as well as hemato-oncologists, and you participants for spending your Sunday morning, afternoon, or evening from whichever part of the world you're logged in. Let me give a flavor of our next weekend activities. Next Saturday, that is 14th of June 2025 from 7 p.m. Indian Standard Time and 8:30 a.m. Central Standard Time, we have Dr. Stephen Ansel from Mayo Clinic, Minnesota, US, speaking to us on nivolumab and brentuximab-based treatment of classical Hodgkin's lymphoma, newly diagnosed as well as relapsed refractory. And the following day, that is Sunday, 15th of June 2025 from 11:30 a.m. Indian Standard Time, we have Professor Dr. Debjit Basu from Pondicherry speaking to us on myelofibrosis, causes and effects. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will pause for a while for you to have our discussions on all our discussions today. So these are our discussions for the day displayed here in alphabetical order. Now it's a time to introduce our guest speaker for the day. We have with us no other than Dr. Hervé Tilly from France. Dr. Hervé Tilly is professor in hematology at the University of Rouen, France. He is the head of Department of Hematology at Centre Henri Becquerel in Rouen. He has focused his activity in clinical hematology, establishing a stem cell transplant activity and creating a regional hematology network. He has served as scientific director of the Centre Henri Becquerel and more recently as general manager. Dr. Hervé Tilly has devoted his research to lymphomas, founding a research group affiliated with INSERM, that is INSERM France. He was a co-founder of the group d'Etudes des Lymphomas I Adult, that is GELA, and more recently of the Lymphoma Study Association, LYSA. As such, he also participated in the conception, implementation, and analysis of many clinical trials, including the very famous popular POLARIX study, of which he is the principal investigator. He has co-authored numerous publications in the field of lymphomas. He is currently the president of European Lymphoma Institute. And today is with us and is going to lecture us on large B-cell lymphoma, European Management Guidelines in 2025. But before he does that, we have our special guest and chief guest for the day, my friend, Dr. Nitin Gupta from Delhi. We all know Dr. Nitin Gupta very well, and it's my formal duty to introduce Dr. Nitin Gupta. Dr. Nitin Gupta is DM in clinical hematology from AIIMS, New Delhi, followed by he did his fellowship in leukemia and BMT from Vancouver, Canada. He is a consultant clinical hematology and BMT physician at Sir Gangaram Hospital, New Delhi. It's my privilege to invite Dr. Nitin Gupta to inaugurate our webinar and give some words of wisdom. Well, thank you so much. I stop over here. Over to you, Dr. Nitin Gupta.
So, good morning to all, and thank you, Amit, for your kind introduction, and welcome, Dr. Tilly. So it is a great honor, and my special gratitude to Dr. M.B. Agrawal and Mumbai Hematology Group, Amit, and dear management team for giving me this honor to be guest speaker on this, chief guest on this special occasion of before the Dr. Hervé Tilly's talk. So for, I think, not taking much time, I would like to say to our younger colleagues who are listening to us and who are involved in this webinar today. Hematology is a great field and it is a growing field, we all know. Clinical it is, and I think we all not only enjoy treatment of our patient, as well as we are doing little bit here and there, contributing to the progression of scientific knowledge in the field. So I started my career in 2006, at that time as a trainee in the All India Institute. And in the short span of 20 years, I have witnessed many of the changes in the treatment of lymphomas and diagnosis of not only lymphomas, but also most of the hematological problems, as well as their diagnosis. Many things have changed. We all know. So I don't. This audience is very learned, and I don't need to tell them how many things have changed. Probably some of them might not recognize. Say, for example, chronic myeloid leukemia. Then that in earlier days, bone marrow transplant used to be the treatment, and then now hardly there are transplant in CMLs. Similarly, in lymphoma, I think the rituximab made the big change in the treatment of lymphoma. Before that, it was only CHOP and CVP and those kind of things. And then now bispecific and CAR T cell therapy have come. So I think the field is progressing very fast, and we need to keep abreast of the knowledge which are getting into this field, and we should be try to use more of those newer advances in the diagnosis and treatment in our patients. I think special thanks to MHG Group, Dr. Amit and Dr. MB Agrawal for organizing those kind of seminars. So, which are with the world leading experts in the field. So you can we get a kind of hands of knowledge, and their um, cutting edge thoughts on this field. In India, I think we are doing good amount of service, as well as problem I believe that uh, is that probably we are not producing that much of scientific innovations and research papers. So for my younger colleagues, and I can only expect for myself also that we need to probably select one field of our area of expertise. We are doing everything. So from seeing to, in India, we do benign to malignant to transplant, whatever comes in our way. So, but I think that is uh, good for a clinical practice, but for advancement of the field, we need to probably more do uh, focused research and do kind of collaborative studies and contribute to the scientific uh, papers by sending abstracts or doing publishing articles in the art journals and so on. So I think that will not only increase our understanding, as well as it will carry forward the clinical or hematology in our country. So I think I will not take much time. So we are all waiting for Dr. Harvey Tilly's talk, and I think hands over to him. Thank you. Thank you again, Amit.
Thank you, Dr. Nitin Gupta, for it. Wonderful words of wisdom, and very truly said, our research is lacking in India. I think the young colleagues must benefit from the research. They must get enrolled into the research, but because that is what is really important along with the clinical practice. Very well said and very truly said. Thank you so much, Dr. Nitin Gupta, once again for as our guest for the day. Thank you so much once again. And now, Dr. Harvey Tilly, the screen is yours.
Thank you, Dr. Dr. Gupta, for this kind introduction and this overview of hematology in India. Today, what I would like to share with you is a kind of overview of the guidelines on diffuse large B-cell lymphoma in Europe. As you know, there was some guidelines written since about 10 years ago, and now we have to renew our guidelines and to update it was done recently. And this guideline will be published in a few weeks, and I would like to share with you. Clearly, it's it's a point of routine to adapt our routine to the care of a patient with diffuse large B-cell lymphoma. So maybe I can share my screen.
Yes, sir. Please go ahead, sir.
Is that okay for you?
Yeah. Yes, perfect.
Yeah. Okay. So this guidelines aiming to provide evidence-based recommendation for the treatment and for the diagnosis follow-up of a patient with a diffuse large B-cell lymphoma in Europe. They are written under the auspice of EHA, the European Hematology Association, and is written by a multidisciplinary panel of experts, including hematologists, pathologists, biologists, nuclear medicine, physician, and also by a patient representative. They contain geographic and professional diversity to reflect the variation in the healthcare system across Europe. A systematic review of the literature was conducted, and the review gave priority to high-quality evidence and to give some pragmatic recommendations that were circulated among the panel for feedback, and the discrepancy were resolved through a series of virtual meetings and consensus discussion among us. So what I propose is to take a look at the different chapters of this recommendation. The first is diagnosis and classification, and then the first line treatment of large B-cell lymphoma, to see some special cases of diffuse large B-cell lymphoma, and then very briefly the treatment of progression and relapse. So, as you know, diffuse large B-cell lymphoma is a complex group of entities. This complexity appears first in the gene expression studies, which describe two main subtypes, each of which was derived from the cell of a different origin, germinal center and activated B cell. Since that time, the acquisition of new data of gene expression profile, chromosomal abnormality, and also mutation landscape made it possible to propose classification which correspond to biological entities, maybe indeed different type of disease that could correspond to their related pathway. These different entities correspond to distinct outcome, and of course, they encourage to consider individuals' treatment. But at this time, this knowledge has not yet changed our daily practice. So when we go back to routine practice, the recommendation now are here to prefer surgical excision for the biopsy as compared to needle core biopsy when it is possible, because to obtain sufficient material in the treatment for further examination. It is recommended to have a diagnosis by a reference hematology pathology laboratory. At least in Europe, there was a network of different reference laboratory. It is asked to our pathologists to have a complete immunophenotype panel, and also to have the possibility to have a FISH examination to look for MYC, BCL2 and BCL6 rearrangement. As the determination of the cell of origin classification is highly desirable for each patient and should be mentioned in the pathology report. Generally, this result is obtained not by gene expression, but by the surrogate of immunohistochemistry according to the Hans algorithm. And you know, in this examination, about 20 to 30% do not have a precise classification, are not classified. It also recommended to explore the expression and the translocation of BCL2 and MYC. As you see here, the expression of BCL2 and MYC are predominant in the activated B cell-like. In this case, and particularly the double expressor are present in the activated B cell. But otherwise, the translocation of BCL2 and MYC are more frequent in the DCB cell-like, and double it are present in this population of DC B cell. But these patients are usually in the spectrum of double expressor of BCL2 and MYC. That's why we recommended to look specifically for a double hit in patients with DCB like and double expression of BCL2 and MYC expression. That's why the recommendation of the panel is to propose to stick to the classification. As you know, we are very happy to have two classifications in lymphoma, and hopefully, for diffuse large B-cell lymphoma, there's no great discrepancy between the WU classification and the so-called ICC classification. And so we ask our pathologists to report the distinction between diffuse large B-cell lymphoma with the distinction of DC and non-DC or ABC if possible, to have also the diagnosis precise of high-grade B-cell lymphoma and some specific subtypes as primary mediastinal B-cell lymphoma or also very specific like leg type or T-cell like. So this should be shown in the pathology report. As a baseline investigation, the PET-CT is a primary examination at baseline. Now, almost all patients could have a PET-CT at the diagnosis in Europe in the early baseline for diffuse large B-cell lymphoma. In rare care, there was no PET possibility. They received a contrast CT if not available. PET-CT is very useful for bone marrow exam, and it's better than bone marrow biopsy in detecting bone marrow involvement, especially in diffuse large B-cell lymphoma. Bone marrow biopsy may be considered for the selected patient in whom coexisting hematology condition is suspected. For example, low-grade lymphoma or myelodysplasia. In case of high risk of CNS relapse, MRI and CSS analysis are recommended to assess CNS involvement. And then, as you know, a multiple prognosis index derived from the International Prognostic Index have been reported. However, at this time in Europe, IPI is widely used and a reproductive index that we use to choose the treatment in patient. So we are sticking in the International Prognostic Index, and of course of CNS IPI. As you know, it's derived from IPI containing more one involvement of kidney and adrenal glands to add to this CNS IPI. That's why at the staging we ask at a multidisciplinarity team discussion to have the determination of the IPI of the CNS IPI. More recently, the metabolic tumor volume is recommended as add to an important prognostic factors that could be examined during this baseline staging. So finally, the panel also recommended the use of the Lugana classification for response criteria, and specifically to use the PET-CT at the end of treatment as soon as possible. So in the first-line treatment of diffuse large B-cell lymphoma is based on age of the patient and prognostic index as it determined. As you know, for years, we know that the first-line treatment is a very important point in diffuse large B-cell lymphoma, where you know that for 40 years ago, it was said that cure must be only accomplished in a patient with frontline therapy. From 25 years now, the standard treatment of diffuse large B-cell lymphoma is defined by the combination of CHOP and rituximab, and this obtain a difference in diffuse large B-cell lymphoma. But as you see on the right panel, the difference in the population treated by CHOP, you can say that the progression-free survival in green and overall survival in blue are very parallel curves, and very narrow space between the two curves, which indicated that there is a few possibility to have efficacy at the second line of treatment. Probably this curves reflect the situation 10 years ago, and maybe it's different now with the CAR-T and the introduction of bispecific antibody, but for the moment we don't know that on the population. So for during these 20 years, there was a lot of attempt to improve the efficacy of CHOP, and there was different ways to adapt intensity with more intensive treatment, with more intensive chemotherapy or more intensive rituximab. It was also the attempt to add maintenance with, particularly with rituximab, to use inhibitors in the combination with R-CHOP, or to change antibodies of, for example, with obinutuzumab. And as you know, most of these attempts do not allow to change the prognostic of diffuse large B-cell lymphoma patient, except from POLARIX. We'll see that later. So now, what is the recommendation? The recommendation is based on the IPI and the age of patient. In patient less than 60, two very important studies are proposed in patient with absence of IPI factors, IPI 0. In these two studies, the first was the FLIER studies from the German group, and it was in a patient less than 60 and with no bulk. It was shown that in such population, 4 cycles of R-CHOP and 2 additional rituximab was the same PFS and the same overall survival that 6 R-CHOP. But in this population, elderly patients more than 60 or with a bulky were not included. So the second study was a study from the LISA, and is this studies patient with no risk factors, but could be a bit elder with from 18 to 80, and some have a bulk. And indeed, it was guided by the results of PET after the second cycles, this intermediate PET, and it could be shown that the patient with a PET negative after two cycles could have only 4 cycles of R-CHOP. In patient with IPI to more than 0 to 1 to 5, the standard is 6 cycles of R-CHOP. As you know, it has been shown by retrospective studies that the overall survival and PFS of a patient who received 6 cycles of R-CHOP were not different as compared to those who received 8 cycles. And then 6 cycles is the standard. And in this population, the question could be, is there a place for radiotherapy in diffuse large B-cell lymphoma? In Europe, we consider that for patients who are in a complete remission, there is no place for radiotherapy in this patient where they are treated, where are in a complete response after immunochemotherapy. On the other side, when patient is with no response after the chemotherapy, probably the radiotherapy is not useful, and the salvage treatment is preferred. So the place of radiotherapy could be only in a very rare cases where there are partial remission in the isolated site. In patients with the higher risk, you have seen the results of the efficacy of polatuzumab vedotin introduced in the first-line treatment of diffuse large B-cell lymphoma. As you know, it is anti-CD79B antibody with a microtubule disruptor, and it had been introduced in the combination in the polar chip. And in this combination was compared to R-CHOP in the polaric study. This population was of untreated diffuse large B-cell lymphoma, aged from 18 to 80. But important point, it was the patient with 2 to 5 factors of IPI, which is the population of this trial. The primary endpoint was progression-free survival as assessed by the investigator. In this, as you know, this trial showed that PFS was significantly better in patients treated with a polar chip as compared to R-CHOP. And it was a case at analysis at 2 years, but also at 5 years, what has been shown very recently. And important point for this population is the fact that there was no different of side effects in the polar chip and R-CHOP. It is a case of global adverse event, but also hematological adverse event, and what could be expected was a neurological difference. So there was no difference on the toxicity between the two regimens. The point that the overall survival in this trial showed no difference between polar chip and R-CHOP. At 5 years, there was a trend with more numerous deaths related to lymphoma in the patient treated with R-CHOP, but this is not significantly statistically significant. These results, in fact, allow to approve the combination in Europe, and it is used and reimbursed in some countries, but not all countries, and about half countries do not use polar chip. So this combination was compared to one combination what had been widely used in the northern countries of Europe, is a combination of CHOP and etoposide, and it was historical comparison in younger patient with high risk diffuse large B-cell lymphoma, and it was shown that the efficacy of the both regimens was quite similar, but the toxicity of diffuse large of polar chip was indeed that CHOP have more toxicity with more hematological toxicity and also neurological toxicity and general toxicity. So it is now admitted that polar chip is preferred to CHOP in this population. So this is now the recommendation according to these results for patients who have no risk factor and no bulk. It is 4 cycles of R-CHOP 21. In case of bulk, as there was very few data in this population, we remain on 6 R-CHOP cycles. And it is recommended for when it's possible to have a risk adapted according to intermediate PET. In patients with IPI to 1, 6 cycles are recommended. And for patients with 2 to 5 IPI, the recommendation is Polar-CHIP, but only, of course, when it is available, and in countries where Polar-CHIP is not available, CHOP 21 is still the standard. As you see that the signals for radiotherapy, only a single site residual at the end of treatment of immunochemo is considered when it is decided. So an important different recommendation is to participate to clinical trials. As you know, there are presently a lot of phase 3 trials ongoing to be compared to CHOP. It is with CHOP and bispecific antibodies, with targeted therapy, with immunomodulators, but also in very high risk patient with CAR T cell, with axi-cell versus CHOP, or with adapted treatment with according to molecular subtypes with CHOP. This trial are ongoing, and the panel of European guidelines encourage to participate to this trial. The other part is, in fact, that the question is whether this CHOP is still or not a comparator, and there are also about some different trial which are comparing not only CHOP but also Polar-CHIP, and the combination of Polar-CHIP and bispecific antibodies have been studied with glofitamab and epcoritamab as when the bispecific was introduced at the second cycles of the treatment. And we have seen that the adverse events seem to be tolerable with some CRS, but not more than 2 CRS events, and with efficacy, which appears to be very important. Maybe in this trial, maybe better than coffee and CHOP. And you know, there is now an ongoing trial which compared Polar-CHIP and Polar-CHIP with glofitamab, and this trial has been completed, and we are waiting for the analysis maybe at the end of the year. So in some case should be considered to give some recommendation. So briefly, this population, specifically elderly patient, as you know, in this patient, the important point to have a geriatric assessment in each patient to see what will be the tolerability of the treatment. And important point is a preface, usually used during 8 days with prednisone, and sometimes added with 1 milligram of vincristine. In this population, the standard treatment has been studied in 3 studies. It's a mini-CHOP with an attenuated dose of chemotherapy, and the results are quite stable, around 60-65% overall survival at 2 years. This treatment is only possible in a patient who had a good cardiac function, and in case of cardiac dysfunction, when the left ventricle fraction is less than 50%, different combination are proposed as RGMOX, for example, which appear to give some good results, but also CVP or COP. And the panel also encouraged to in this population to participate to clinical trial. This trial, which compare Air Mini CHOP and Polar Mini CHIP, is ongoing in the northern countries of Europe, and we hope it will be completed. The recruitment will be completed very soon, and we are waiting for these results. But apparently, the combination seems to be tolerable, at least at the first sight. And we are encouraging to participate to chemi-free studies in this patient. As you know, some early studies have shown very encouraging results. Is a case of ibrutinib, lenalidomide, and rituximab, and also zanubrutinib and lenalidomide and rituximab, but also the possibility to use bispecific antibodies at the first line, or alone, or in a combination with Polar CHIP, and all these results are in study, and we are waiting for them. In the case of double hit lymphoma, the recommendation of the guidelines is related to the fact that CHOP not appear to be the best treatment, specifically in patients with advanced stage disease, and it is recommended to use more intensive treatment, CODOX or CVAD or DA-EPOC. But as you know, these results are not so good, and we are very interested in the possibility to introduce CAR T cell in the case where the response is not complete very early, and this is not in the recommendation, but a lot of centers are proposing to a CAR T cell when at second cycles they are not complete response after two cycles of the first treatment with R-CHOP or with more intensive treatment. Special treatment of primary mediastinal B-cell lymphoma. As you know, it is about 5% of diffuse large B-cell lymphoma, mostly affecting young patient, and with quite good results, with more than PFS at 2 years of 85%. And in this disease, PET evaluation is particularly important at end of treatment, but also for the prognosis, intermediate PET-CT. What we have found that dose intensive treatment in primary mediastinal lymphoma was more efficient than R-CHOP 21. It is a case for R-CHOP 14, for ACVP, but also for well-known dose adapted R-epoch, and these are the recommendation. The question was also what happens at the end of treatment with a PET CT. It appears that the patient who had a Deauville score of 4 is the same that the patient with a Deauville score of 1 to 3, and only patient with a Deauville score of 5 has an important risk of relapse and of death. And indeed, this case is a case for patients who receive radiotherapy, but also for patients who didn't receive radiotherapy. It seems that a patient with a Deauville score of 4 has a good prognosis. That's why the recommendation is to use intensive treatment with this regimen to avoid CHOP 21, and the importance of PET evaluation at the end of the chemotherapy. No radiotherapy in patients with CMR. This has been described. And in case of Deauville score 2-4, to propose a biopsy, which is very difficult. So it is very processed. So strict follow-up with PET CT, or in Deauville score 2-5, salvage treatment and biopsy only in double full cases. Finally, one special point is CNS prophylaxis. As you know, this is a very controversial point, and what we can say that intrathecal methotrexate is probably not very efficient, because the diffusion of methotrexate in this case is very low, and when intrathecal is only used as a prophylaxis, in this case there is a lot of CNS relapse. High-dose intravenous methotrexate is very controversial too. A lot of retrospective study, as there is no prospective study in this point. Our studies didn't show a very convincing data to encourage the use of high-dose methotrexate. So it's very difficult to encourage this. And at least when we used high-dose methotrexate, it is better to use it at the end of treatment, probably not more efficient, but at least not to interfere with the delivery of R-CHOP. Maybe the use of intensive treatment, as is the case with our ECVBP here, is better to reduce the risk of CNS relapse. In this patient where our ECVBP received intrathecal and intravenous high-dose methotrexate. So the recommendation now is to insist of the uncertain efficacy of prophylaxis and the risk of toxicity, specifically in elderly patients, to propose to in patients with the CNS 4 to 5 to propose MRIs and precise CSF analysis containing cytology, but also flow cytology and ctDNA in CSF, to look for the possibility of present CNS disease at baseline. And in case of high-risk patient, if high-dose methotrexate is considered, to consider it after R-CHOP, and in younger patient to propose more intensive treatment if possible. So at this time, briefly, the recommendation of the panel of on second line. So, which was indeed, you will see, very standard. It should propose, of course, biopsy in case of relapse. It is strongly, very strongly recommended, and also to allow to look for expression of CD19, which is very important, and CD20. As you know, in this population, the time of relapse according to the first line is very important, with a difference established between early relapse in the first year of the first treatment compared to more than 1 year, with a very different seen in patient at least a year. Patient will receive the salvage and autologous stem cell transplant. So that's why it now established to have a different treatment according to this sequence. As you know, in the patient who relapse in the first year of treatment, there was three trials comparing CAR-T and standard of care, and two of them, the one with axi-cell and the one with liso-cell, shown an advantage of event-free survival in the population of patient treated with CAR-T cell as compared to standard of care, which compare salvage treatment and autologous stem cell transplant in responding patients. You know, in the ZUMA 7 and in transfer, there was a better PFS, and but there was a more CRS toxicity in the patient treated with axi-cell as compared to liso-cell, but the efficacy on PFS was almost the same. Overall survival was significantly better in the axi-cell trial with axi-cell, which was not reached in the liso-cell, probably because the patient in the liso-cell received crossing over, and all patients will relapse after or was refractory to standard of care, received a CAR-T cell. So this is an argument to say that it is better to use CAR-T at the second line as better than in third line. It is a supplemental argument. As you know, in this population, some patient could not receive the standard of care comparing with containing autologous stem cell transplant. Is specifically patient more than 65 years of age, and it was two studies have shown that some of these patients could receive CAR-T cell treatment. This is the study of the phase 2 study of the LISA, and they showed a complete response in this relapsing patient of more than 65 years of age, of near 80% of complete response, with some 8% of CRS symptoms, and neurological symptoms may be more important, with 15% of neurological events in this patient, and a lot use of tocilizumab, but a PFS and OS, which was quite important. That's why now in patients who are eligible to CAR-T, it is proposed CAR-T population treatment. But as you know, a lot of these patients are not eligible also to CAR-T because they are a poor performance status or because their disease is more evolutive, and we know that patient who has a high ALH level or high tumor burden are not eligible to CAR-T. In this population, we have some immunotherapy, immunochemotherapy with R-GemOx or a possibility of Pola chip when Pola is available. Tafasitamab and lenalidomide is also could be used, but if you remember, in this population, the results are not less interesting now because in the early studies, the only patient were patient who were treated after 6 cycles of relapse. And a very important point is the fact that now the combination of GemOx and bispecific antibodies, specifically clafitamab, has been shown to give a better PFS and a better overall survival in patients treated with a combination with bispecific. And you know, this is an ongoing studies with epcoritamab is also ongoing. And another point for a patient relapsing is the combination of GemOx and Pola chip shown a better PFS and a better overall survival of this combination with including Pola chip. We know that, and it will be shown in the next few days in ER and in Lugano. So at this point, for patients who are not eligible to CAR-T, Clafi GemOx is preferred treatment if possible, if available. For patients who will let relapse, the standard is to use autologous salvage and autologous cell transplants for patients who are sensitive to platinum treatment. In the third line, a patient who didn't receive CAR-T previously could receive CAR-T cell, or otherwise, a patient who relapsed after CAR-T could receive bispecific antibodies and probably bispecific antibodies and GemOx. So to conclude, the panel also gives some recommendation about the follow-up of patient and insist on the evaluation and information of the treatment at the end of treatment, and to focus monitoring during the 2 years after complete remission in patient, specifically because after 2 years, it appears that overall survival of patient treated with diffuse large B-cell lymphoma has the same overall survival at this time. So it is recommended not to use CT or PET to follow up, but be aware of possible symptoms, have information with a general practitioner, and to use CT or PET in case of any symptoms. It is also insisted on the long-term effect of chemotherapy and the recommendation of a lifestyle with physical activity, with diet and something that smoking cessation. So I hope that these guidelines will appear very early now in the press, and we are waiting for you. And thank you for your attention. Thank you very much.
Thank you, Professor Tilly, for a wonderful talk and evaluating the updated guidelines in 2025 for diffuse large B-cell lymphomas. Thanks a lot, sir. Wonderful update. Fantastic overview of all the guidelines in 2025 as to how we must approach DLBCL in refractory cases as well as in primary setting. Thanks a lot, sir. So now I request all our discussants to please put the hand in sign so that we can start our question answer session with Dr. Tilly. Yes, we have first Dr. Malini Garg. Please.
Thank you, sir, for the clear and crisp talk. It was such an excellent talk and the concepts got clear. Then I have one question. So if a patient has bilateral testicular involvement with DLBCL, so what would be your recommendation how to approach this kind of patient with bilateral testicular involvement?
Sorry, very difficult to hear you.
So patient of DLBCL with bilateral testicular involvement.
With testicular?
Bilateral testicular involvement, what would be your line of approach?
Yes, there was some recommendation for this patient. The experience in this setting is produced by the patient of Italy, and what is proposed in the guidelines is to 6 cycles of R-CHOP. But in this population, they have received in the Italian experience a prophylaxis with both intrathecal injection and high-dose methotrexate, and also contralateral radiotherapy of the testis. That is radiotherapy on the remaining testicle.
So, sir, thank you, sir. So, is there any rule of surgery? There is bilateral testicular involvement in these patients to surgically remove the testes. Also,
surgically,
is there any rule?
No, it's not surgical. It's the experience of the Italian group is to use radiotherapy as a 30 rays.
Okay. Thank you, sir. Thank you so much.
I would say that this is very discussed because it is a very Italian proposal, but in different countries, some doctors are reluctant to propose a radiotherapy depending on the age of the patient.
Thank you, sir.
Thank you, Dr. Malini. Dr. Roshni Pandey, ma'am, your question, please.
Thank you, sir, for making the concept so clear. The first question is, in your personal experience or practice, would you change the treatment or would you modify treatment based on cell of origin, especially in elderly patients, like adding ibrutinib, lenalidomide to R-based chemotherapy?
In our daily practice, no at the first line. No after the first line. It could be considered in an elderly patient in relapse, for example, to introduce ibrutinib in second line or ibrutinib and lenalidomide and rituximab in third line is possible, but not in first line. In first line, we use our mini-CHOP. I think that this patient could be very interesting according to the efficacy of Pola-R-CHP. As you know, we know that subgroup analysis of Pola-X have shown that the bigger difference between Pola-R-CHP and R-CHOP was in the population of ABC population with more efficacy and clearly at 5 years, an advantage on overall survival is this patient who are treated with ABC. So I would say that if you have the possibility to have a polar chip in first line, you use it in a patient with ABC, probably.
Is there any patient or subgroup where end of treatment PET CT can be omitted? Because we are a resource constrained country and I work in a resource constrained area. Omission of end of treatment PET.
Excuse me, at the end of treatment,
in any circumstances, can we omit end of treatment PET scan? Because if the patient is not affording for PET scan, can we omit end of treatment PET scan in any circumstances or any subgroup of patients?
Our recommendation is to use it at the end of treatment to be sure that the patient is in a complete response. And so I don't know if you're it is for the patient and for the doctor also to be sure that the treatment is indeed in our practice, in my practice, a PET, of course, at baseline, but also intermediate PET at 3 to ensure that we are in the way to have efficacy, and then to confirm at the end of treatment that we are in complete metabolic response, but no follow-up.
The last question is in gastric diffuse large B-cell lymphoma. Sometimes they may have an indolent component. So would you absolutely say that radiation is a big no, even when there is no residual disease on the end of treatment PET? So no radiation?
No radiation. No radiation at the end of treatment when the patient is in complete response. There's no radiation. No radiation, but probably special follow-up in this patient when we think that it could be the possible mild transformation of a mild gastric lymphoma. So we have to propose the same cell variants that in a mild gastric lymphoma, and with a risk of recurrence of MALT, but also of gastric cancer.
So we need to follow up both with endoscopy and PET, or only one of them in such a situation?
Endoscopic, yeah.
Endoscopy. Thank you, sir.
Thank you.
Thank you, ma'am. Dr. Nitin Gupta, your question.
So first of all, thank you, Professor, for excellent talk and updating us with the European guidelines on B-cell lymphoma. So I have two questions. One is, what is the recommendation about T-cell rich B-cell lymphoma? So we see it quite often nowadays, and I think the prognosis appears to be poorer, and we don't have how to treat. And the second question is, you said that CAR T-cell therapy in relapsed refractory lymphomas. So the thing is there any circumstance where CAR T-cell, or sorry, autologous transplant can be preferred over CAR T-cell therapy in relapsed refractory lymphomas, or the CAR T-cell is on the upper hand at all the times?
For the second question is there some circumstances where the CAR T is used in late relapse? Is that the question? Sorry.
Yes, sir. So, so because if say somebody is we don't have CAR T-cell available to many of our patients,
Yeah.
we can use autologous transplant if they go into a chemosensitive disease or get into a remission. So we can do autologous transplant easily. So is there any circumstance where we can do autologous transplant rather than pushing for a CAR T-cell therapy in relapse patient? So somebody
It
who
is
has a kind of late relapse or early relapse or kind of.
Yes, yeah, it is indeed is quite clear for us in our practice. That is, the CAR-T are approved, that reimbursed in the patient who are relapsed in the first year. So as we are the CAR-T are paid so according to the results we prefer in the first line, we prefer to use CAR-T. In the after 1 year, we cannot use it because it's not approved. So at this moment, we cannot use at this case salvage and autologous stem cell transplant, and CAR-T is not approved at third line. In case we are not sensitive to salvage or patient who relapse after autologous stem cell, then we can use a CAR-T at the third line. Excuse me, but the first.
Yeah, the first was the T cell rich B cell lymphoma, sir.
Sorry.
So T cell rich B cell lymphoma.
This rich, you know, this some difference were not considered to be different for treatment by the panel of guidelines. So T cell of IF, EF, or some, there's no different, no proposal, no different proposal. Do you have some proposal for B cell rich T?
No, sir. The probably it, I think the relapse rate appears to be higher, and their survival is inferior compared to the DLBL NOS. So I think
Yeah.
there is a need to, I think, to come out with something or to how to better treat those patients.
Right. Interesting.
Thank you, Dr. Nitin Gupta. So from the same note, any subgroup of patients would you like to use bispecifics first rather than CAR-T?
Sorry?
Any subgroup of DLBCL patients, would you like to use bispecifics first and then CAR-T, who are relapsing within first year of therapy?
For the moment, no, because for the moment there is a few reasons to use it, but probably in the future it will be the case. But for the moment, it is simple that that bispecific are approved in third line. In third line, so we cannot use it in second line. But probably in the future, yes. And when we see the results of GOVIT and GEMOX, probably we have to discuss a lot of patients because the side effects are different and the cost is different too. So we have to discuss this in the future, probably, yeah. But today we don't have the possibility to use bispecific in second line.
Thank you so much, sir. Thanks a lot. Dr. Satish Kumar, your question, please.
Thanks, Amit. Thank you, Professor. I have a patient with EBV positive DLBCL. So you manage in the same way as regular classical DLBCL with R-CHOP, or do you prefer DA-EPOCH or EBV positive DLBCL?
Yeah, in this population, we have to we use indeed we use the same. You know, we indeed in a large part of the Europe there is a few of use of EPOCH because it's very difficult to use it. You know, you have to have the patient as an inpatient for 3 days. So it is really difficult in our hospital. And so it's very different. In EBV,
Dr.
नया स्टाफ क्या सुमन है?
नहीं वो उसको निकाल
क्यों? हाँ?
पता नहीं
Dr. Rashmi ma'am,
Thank you.
please
And
mute
in,
yourself.
in, in EBV, we use usually is clear diffuse large B-cell lymphoma with EBV. We use R-CHOP, but where there is lymphoproliferation associated to EBV, we propose treatment with rituximab only during 1 month, and if only if there is no complete response, then we use the R-CHOP. But a small fraction of patients who are lymphoproliferative disease could be used by rituximab only.
So what about double expressor DLBCL?
No difference.
No difference.
You don't use difference. And you know, it's also very difficult we give recommendation to use fish and to have double translocation, but clearly it's a recommendation, but cannot be followed by a lot of patients, a lot of centers where fish are and fish is only we have some days or some weeks to obtain the results of fish in Europe.
So, sir, apart from double hit lymphoma and primary mediastinal B-cell lymphoma, is there any other subgroups where you recommend DA epoch or?
No, what we have seen with mediastinal lymphoma, that there was no apparent difference between DA-EPOCH and CHOP14. CHOP14 only CHOP21 was below, was worse than DA-EPOCH or and indeed, you know, DA-EPOCH is very different. It's very few used in France, but it's used in northern country. So it's different from one to other. But the results seems to be the same for mediastinal. And you know, it's so difficult for double hit to have results with a double hit. Probably intensive is better, but it is not proved. And what we have seen in our previous trial, that patient with what are not the problem was with a double hit is a double hit with a very advanced disease. In this case, probably the R-CHOP is not enough.
Thank you, Professor. Thank you.
Thank you, Dr. Satish Kumar. Dr. Akanksha, your question, please.
Yeah, thank you, sir, for the wonderful lecture. So I have a question regarding, primary B-cell lymphoma of the breast. So for the primary breast lymphomas, is there any difference in the approach of the treatment, or is it like to be followed similar to the DLBCL approach that you showed?
This is the global question of the so-called immune privilege lymphoma, immune privilege site lymphoma. Yes. So we applied in the guidelines. We only consider the primary mediastinal, the testicular, and the intravascular. There was no special recommendation about breast, and I say we have few arguments to change the treatment in breast cancer, breast lymphoma, indeed.
Okay, sir.
Do you have any suggestion?
So, sir, I recently had a stage 2E ABC type of breast lymphoma, and for that patient, I actually gave 3 cycles and I did the PET scan, and that was in CR. So it was a dual,
Yeah.
I think 2. And then I gave a 4th cycle, but I also gave the involved field radiation to the breast tumor. That, and at the beginning, although the size was less than 7.5 centimeter, but still I gave radiation to the primary breast mass.
All right. It's interesting. Yeah.
Yeah. And so one more question, like for patients who have double hit or triple hit lymphomas and elderly, so above 80 years, so what is your approach for treatment?
Indeed, it's quite rare, but usually we cannot in very elderly we cannot change the treatment so we used even if possible maybe we will be interested to use full dose R-CHOP, but in a very elderly patient we stick to our mini CHOP.
Okay, so even for the double hit ones.
Even after 80 years, yes.
Yes. Okay. Sure. Okay. Thank you.
Thank you, sir. Thank you, Dr. Akansha. Dr. Aryant, your question, please.
So thank you, Dr. Tilly. So my question is regarding in the context of cardiac comorbidity in patients with DLBCL. So 2 situations. One patient who has a known coronary artery disease has been stented or has undergone a CABG, but his ejection fraction is normal. And the second situation where the ejection fraction is reduced. So how do you tackle the 2 situations, and at what level of ejection fraction do you modify the anthracycline? And if you modify, what is your protocol? Whether you do a mini CHOP or you switch to etoposide? Was I audible?
I'm not sure to catch the question.
I'll just tell you his question is, in those patients who have got a history of coronary artery disease,
Yeah.
he has got questions regarding patients with coronary artery disease. One group of patients who come to us with ejection fraction absolutely normal. So should we stick to anthracycline-based regimen or should we continue without anthracycline, number 1? And those patients who have got diminished ejection fraction, what would be your line of approach?
Yeah. Indeed, when we stick at the ventricular fraction. If the ventricular fraction is okay, we used full dose CHOP or mini CHOP. The case is in case where there is a decrease in the fraction. Usually we use RGMOX, which could be used. Some countries in Europe use pegylated anthracycline. I'm not sure that is very different, but we don't use fraction of anthracycline, for example. We use in this case we use RGMOX. Probably in the future we can use bispecific and GMOX.
Perfect. Any other question, Dr. Aryant?
Okay. So at what ejection fraction do you dose modify, and do you tend to use etoposide in place of R-CHOP is one regimen which we tend to use. So your take on that?
No, but it could be to use CHOP, which is etoposide, outside of anthracycline is a possibility. Yes, it's a possibility that and it is proposed in the guidelines too. Yeah. Yes.
And any cutoff for the ejection fraction, sir? Beyond that, you will go for etoposide? Cutoff for the
50%.
ejection fraction?
50%.
50%. Okay, sir.
50%.
Thank you, sir. Sir, we have some questions from the audience. Any other question, Dr. Aryan? Yes. Okay, thanks a lot. So we have some questions from the audience. One question is there from Dr. Lily Wong. If the histopathology of DLBCL shows results of only CD79A positivity and not showing any results of CD79B, can we still use polatuzumab in those patients who are just CD79A positive with unknown CD79B status?
Sorry, could you repeat it? Sorry.
So sometimes in the immunohistochemistry results on the histopathology report of DLBCL, we get only status of CD79A positivity, but we have no status of CD79B. So in such settings where we don't have any status of CD79B and we say that in the report we have got CD79A positive only, can we still go for polatuzumab? Because we don't know whether CD79B is positive or negative. Only we know that it is 79A positive. Can we go for polatuzumab still?
Yes. For what we know about polatuzumab is when we during the first studies of polatuzumab and the efficacy of polatuzumab as a single agent was not related to CD79B expression of the surface of the cells. So from this moment, it's a bit like brentuximab with CD30. That is, there is no parallel between the expression of the antigen as the surface of the cell and antibody. So indeed, we didn't examine, we didn't look for expression in this case. One of important question is the mutation of CD79B a problem in the and this is under study now in POLARIX if there is a difference for CD79B mutation, because the POLARIX is probably POLARIX is probably more efficient in some molecular subtypes like MCD, where CD79B mutation are found. Much more than expression.
Thank you so much, sir. Another question is from Dr. Bhavin Shah, sir. He has a case of patient of DLBCL who is stage 1E, that is extranodal lesion. IPA score is 0 to 1. Should this be treated as same as stage 1 nodal disease, or should we consider more cycles of R-CHOP and followed by ISRT?
Sorry, once again, it's difficult to.
So patient with stage 1E disease, extranodal disease, IPA score of 1, 0 to 1. Should this be treated as stage 1 nodal disease, or should we add some more cycles of R-CHOP or followed by involved site radiotherapy?
Yes, is it stage 1 extranodal?
Yes,
what we're
stage
doing
1
now.
extranodal, IPA 0 to 1.
Is 0 to 1 IPI. I think it's according to the guidelines, with 0, this is indeed with normal LDH. When a normal ADH and stage 1, it's four cycles, and this LDH elevated LDH stage 1 with LDH elevated is IP to 1, and then we use 6 cycles. This could be discussed probably according to the response at the intermediate PET, and I would say that the PET after 2 cycles is negative. Maybe you can stick to only 4 cycles of R-CHOP.
Perfect. But this will be same as for external also.
Yes,
That
yes.
is
Yeah,
not treated differently.
yeah.
And any
Yes.
role of ISRT?
Clearly, in the LISA's study, comparing nodal external was not different. There was no different.
No difference. Thank you, sir. Another question is from Dr. Mehak Trehan. How do you manage patients with primary refractory disease in centers where CAR T cell therapy is not available?
In which question? Sorry.
In those patients who are not affording for CAR T, in
Yeah.
refractory patients who are not affording for CAR T, or in those centers where CAR T is not available, what would be your line of approach? How do you go about that?
Yeah, in this case, I think now in Europe is rare, but it could be in some countries, and in this case, we stick to standard treatment treated years ago with salvage and autologous stem cell.
Great. Thank you, sir. Another question is from Dr. Shyam. Any experience of intrathecal thiotypa for CNS prophylaxis for high-risk DLBCL?
Intrathecal?
Thiotypa.
What is, sorry?
Intrathecal thiotypa.
Therapy? No, absolutely no. Absolutely no. No, you use theoretical Chotipa in the conditioning of our primary CNS lymphoma. We use Chotipa in the conditioning regimen before autologous stem cell transplant in this population of primary CNS disease.
Perfect. So there is no role of intrathecal thiotypa.
No experience, absolutely. I didn't even know that it could be used.
Exactly. Another question is from Dr. Lee Ki Tat, a patient of DLBCL who is 50 years old, male, has got DLBCL of the ileum, stage 2, IPI 1. Does he need any additional therapy, example, consolidative radiotherapy or CNS prophylaxis besides R-CHOP 21 for 6 cycles?
Stage 2?
So, 50 years, male, DLBCL, 50 years, male, DLBCL of intestine, small intestine, stage 2,
Yeah.
IPI 1,
Yeah.
given 6 cycles of R-CHOP 21. Anything else to be done?
No. I would say no.
No.
Specifically, no radiotherapy in the intestine is so difficult. Only 6 cycles, of CHOP and evaluation with PET CT for me at 3 and end of treatment. Yeah.
Perfect.
So sometimes intestine is sometimes difficult to PET evaluation, specifically in patients who have diabetes, where it's very difficult to have who could have a non-specific hypermetabolism in the intestine in the patient who are we have diabetes.
True, sir. So only 6 cycles of R-CHOP 21 enough for DLBCL stage 2 intestine. Okay, sir.
Yeah, I would say that.
Yeah, thank you, sir. Another question from Dr. Mehak Trehan. Do you recommend CNS prophylaxis in 2025 for double expressor lymphoma and for double hit lymphoma who have got no high risk of CNS IPI or no extranodal sites involvement?
This is a very good question. Indeed, according to the guidelines, the guidelines said the it's a bit complicated. Indeed, when there are a high risk of CNS relapse, that is CNS IPI 4 to 6, then we have to, at baseline, to use MRI and use a complete examination of CNS, CSF with cytometry and, if possible, ctDNA. So in this case, we can find, and then these patients are treated like primary CNS disease. Indeed, in patient with, we don't propose specific treatment in double expressor, but clearly for patient who have a double hit with double translocation, it's not written in the guidelines, but I will prefer, I will propose a prophylaxis with high-dose methotrexate, and probably in the context of intensive treatment, because in younger patients with intensive treatment and prophylaxis with high-dose methotrexate. The problem is in elderly patient with a double hit, we don't know what to do.
True, sir. Thank you so much, sir. That was fantastic answer. Any other question? Yeah, perfect. So there are no other questions. Any discussions? Want to ask any other question? Well, so sir, there are no more hand raised signs. Sir, thank you so much.
May I ask you a question?
Yes, sir.
Yes. What are the guidelines in India? Do you have some guidelines? And
we are
it is
your guidelines.
No guidelines. And
we are following your guidance. All our UK-based guidance, what we are following, but it depends upon our case-to-case basis.
Yeah.
Most of DLBCL we do follow. Most of the centers in India is our mini. With those patients who are not going for anthracyclines, we do, as Dr. Aryan said, we also go for RCEOP.
Yeah.
Some of the patients we also try RGMOX in those patients who are not going for anthracycline-based approach, like those patients who have got coronary artery disease, we also try for RGMOX. Some of the patients, we have very well number of patients, we are on RCEOP, COP. And elderly patients, our elderly patient is quite a different lot, sir. For you, more than 80 years may be the lot of patients, but for our more than 70, 75 is elderly in Indian settings. So may not be able to take the full dose of R-CHOP in our elderly settings, but so we go for even 75 years of age also we go for R-mini-CHOP in some people, some centers. So that is case by case approach we follow in India. Definitely there is a big dilemma in India too, sir, for CNS prophylaxis, whether to go for or not to go for it. But in most of the center, as you said, basically those patients are very high risk of CNS IPI. Some of them do follow with the high dose methotrexate at the end of the R-CHOP 6 cycles and not R-CHOP intercalate. We don't intercalate it, but most of the centers we go for end of treatment R-CHOP because intercalating becomes a big problem in India because of toxicities. So that is what we are doing, and we are following most of the European guidelines till date.
Right. And I know that the CAR-T used
So CAR-T we have started using most of the centers. We have CAR-T now, and we have in Delhi, we have in Mumbai now, as well as Pune. We have CAR-T, and people are opting for CAR-T also, and we are proceeding for CAR-T also in many centers now. So patients who are relapse refractory within first year, and definitely we are pushing the patients for CAR-T. Yes.
And the access
access is it's little bit problem because in major cities of India only there are CAR-T. It's yet to come for the 2-tier and 3-tier cities in India. But I think with a couple of days to go, I think in India also the CAR T will become the most popular thing for DLBCL.
Right. Okay.
Yeah.
So, and the access of polatuzumab or to bispecific.
We have got well assessed all over India, so it's available. And regarding the bispecifics, yet we need to import glofitamab because that is what is available, but only on import basis, glofitamab plus obinutuzumab. So most of the patients we are giving only single agent glofitamab followed by R-GMOX, or we are also trying for obino followed by glofitamab.
On top line.
No, in relapse setting.
Relapse setting. Yeah.
Relapse refractory setting or the third line setting.
Right.
Is what most of the physicians here in India do so.
Okay.
So importing the patients with glofitamab, that's all.
Right.
So that's the thing what we are doing. But most of the patients we are not affording for glofitamab, but in those patients we are offering them CAR T.
All right. Okay.
Yes.
Oh, very interesting to share different opinion. Yeah.
Thank you so much. Thank you for updating us all the European guidelines in 2025. It was fantastic, and the way you narrated the guidelines, it was an eye opener for all of us, and it was good learning for all of us. So, thank you so much.
Thank
to
you for your
participate in
invitation. Thank you for your invitation,
this.
and thank you for this discussion. Thank you very much. Bye bye.
Thanks a lot, sir. Thanks a lot. Truly honored, sir. Thank you.